It is an honor for me to warmly welcome you all to the second event to mark World Cancer Day and the one-year anniversary of the United Action Against Cancer, a pan-European cancer movement from grassroots to government spearheaded by the WHO Europe. Yesterday, we heard from the regional director, Dr. Hans Kluge, who addressed the questions from the US ambassadors about engaging youth in cancer policy and ensuring evidence-based policy decisions. We believe that youth voices are key in a transformative agenda for health and the well-being. This is about improving our responses for a better future, and we can only achieve progress if we build together. We also had the candid conversation between the WHO Euro Cancer Ambassador, Aaron Anderson, who is a cancer survivor and the inspirational leader for young people and many of us, and the panel of experts on risk factors, tobacco use, the alcohol, and effective policies we have in our hands to implement and scale up. Screening and its importance, as well as importance of the comprehensive cancer care from prevention to early diagnosis, quality treatment, and follow-up. We also heard about the inequalities in cancer and the better data that are needed to address these inequalities in our region. These are all flagship initiatives and the solutions supported by the United Action Against Cancer to understand how we can move forward with bold actions that can impact cancer prevention and treatment. Today, in follow-up to yesterday's publication of the new cancer screening guide, we will go more in depth on this topic, hearing country experiences and the examples of implementation of the effective screening programs, as well as the question and answer session with several of our partners active in this field, as partnerships are critical in ending the cancer. Now I welcome Allison Ekberg, WHO Health Policy Advisor, to facilitate and host today's event. Thank you all so much for joining us today.
Thank you, Nino, for that wonderful introduction. Good evening, and thank you for joining us for the second segment in our event for World Cancer Day. My name is Alisson Ekberg, and I'm a Health Policy Advisor for WHO Europe. We begin today by reflecting on the first year since the launch of United Action Against Cancer. And to do that, I want to share a video that touches both on the challenges we face as well as what gives us hope. Let's watch this video.
For those diagnosed with cancer or in care, survivors, support circles, healthcare workers, and those for whom we hope our actions mean never embarking on this journey. For decision makers at critical intersections, managing tensions where political and social demands collide, exposed to powerful forces struggling against the tide. We offer you an anchor. Together we'll hold firm. From grassroots to government, roles for everyone, no one forgotten. Today we reflect on what we've learned. We summon courage, imagination, and ambition. Drawing from the well of our collective wisdom, we listen, and we elevate our vision and action towards cancer elimination. Our system struggled, disrupted by COVID. New cancer cases dropped dramatically because patients didn't come. They'll come belatedly. And so we foresee a huge increase in cases, not diagnosed in time, not treated in time. Prevention, early detection, diagnosis, treatment, palliative care. We're building capacity where it's vitally needed, giving people in remote areas access to cutting-edge treatment. The results? Immeasurable. Life for women. Fewer orphaned children. For the 9 people diagnosed with cancer this minute and every minute, we can do better. We know what works. Invest wisely. Our strength lies in our unity.
What a moving video. I think we can all relate to the messages we just heard. And indeed, our strength is in our unity. And it's through coming together that we will achieve the vision of eliminating cancer as a life-threatening disease and our commitment to leaving no one behind. Now, as the video said, we reflect on what we have learned. For this, we will turn to 2 country stories and to 2 speakers who will share different lessons that they learned from implementing cancer screening programs in their countries. First, we go to Urška Ivanuš in her capacity as the head of the National Cancer Screening Program, ZORA, in Slovenia. Urška.
Hello from Slovenia. I was asked to share the Slovenian experience in how we managed to lower the cervical cancer burden with organized screening and why the opportunistic ad hoc screening failed to bring the long-term results. In Slovenia, we established the National Cancer Registry in 1960s, and that enabled us to monitor the cervical cancer incidence. And we observed that despite the decades-long opportunistic screening, the cervical cancer incidence increased in 1990s, and we were not alone. Similarly was observed in other European countries where organized screening was not implemented, but not in countries where it was. A few enthusiastic experts with knowledge and will decided it's time to take action and implement organized population-based screening on the continuum of cervical cancer prevention and care, including identification of women, invitation of women, screening, triage, diagnostic, treatment, and follow-up after treatment. The decision was made about screening age interval and test, and the guidelines were prepared by the multidisciplinary group of experts and Ministry of Health on board. It was tough. There were competing interests with our interests of doing what's best for women and prevent what is preventable. And at that point, it was necessary that legal regulations were set and support the screening program, the organized screening, as well as the establishment of screening registry, which enable us then to monitor and evaluate the screening quality and impact. It was necessary because there were doubts among clinicians and women that the organized screening will really lower the incidence of cervical cancer, because we have actually prolonged the screening interval, limiting the screening age, and the recall rate due to the positive screening test results dropped from 15 to 5% shortly after the introduction of organized screening due to the higher quality of screening smears and cytology. But it turned out that we were right. Due to the increased coverage, increased quality of all screening services, the cervical cancer incidence dropped, and it has reached the record low levels in past years, almost reaching the elimination threshold. Cervical cancer is the only cancer where we have enough knowledge and technology available that we could prevent almost every case with HPV vaccination, screening, and treatment. And screening plays an important role in this equation. It is on us to reach women with information that could save their lives and provide them with easy access to the best possible services on the continuum of cervical cancer prevention and care. And it's difficult, but with shared vision, collaboration, with adjustments and with monitoring and adjustments, with strong governance, and with following the evidence, it's not so difficult also. And the success is measured in women's lives.
you, Urshka. First of all, I want to congratulate you on your achievements in Slovenia. And I think this is an incredible example of the impact of organized and evidence-based population screening in its effect on reducing and preventing cervical cancer. Next, we will go to Dilyara Kaidarova, Director of the Kazakh Research Institute of Oncology and Radiology, to hear about Kazakhstan's decision to de-implement non-evidence-based cancer screening programs. Dilyara?
Dear colleagues, I would like to thank the organizers, WHO, for the invitation to speak today. The National Cancer Screening Program in Kazakhstan started in 2008 with cervical and breast cancer, in 2011 colorectal cancer, and in 2013 esophageal, stomach, liver, and prostate cancers were added to national program. In 2015, we analyzed results of screenings. There were low coverage, poor quality of screenings, absence of screening registry, low detection rate of precancer and early stage, lack of IT support. Together with WHO, we raised the problem with the government in order to improve quality of screenings. In 2016, upon the request of Minister of Health, the WHO Impact Mission was invited to Kazakhstan. As a result of the review, the following recommendations were given: to increase the coverage more than 70%, to monitor precancer cases, to update clinical guidelines, to monitor of 5 years survival, and cancel esophageal, stomach, liver, prostate cancer screening for dynamic control of high-risk population. Before the implementing of these screenings, during 2 years, we worked with the teams of experts in terms of equipment analyzing and medical staff trainings. The proposal to stop screening of esophageal, stomach, prostate, and liver cancer sent to major medical centers, oncology hospitals, and medical universities. And teleconferences with all levels of regional medical organizations were conducted. Huge media campaign informing about change in screening programs were provided. After cancellations of 3 programs, the early detection continues among high-risk groups and added to cancer control plan in 2018. Today, Kazakhstan on the way to implement HPV-based screening, breast cancer screening at high risk of BRCA mutations, and automated quantitative FIT test for colorectal cancer. Pilot project for low-dose CT lung cancer started in north part of Kazakhstan. And I would like to thank the WHO Agency for Atomic Energy for help and cooperation in improving screening program in Kazakhstan.
Your experience is also very helpful, and I think it can be challenging to change course, but ultimately we have to follow the evidence if we want to have the expected results from screening programs. So thank you for sharing your story. Thank you both. Now, in the spirit of drawing on our collective wisdom, we have invited some of our partners and colleagues to join us virtually in the studio today for a Q&A session on cancer screening. Thank you, panelists. It's so great to see you, and thank you for joining us today. So I think let's start with introductions. And if you could give me a hand as I introduce you, it will help everybody in our audience. So first we have Andre Carvalho. He's a scientist with the International Agency for Research on Cancer. Thank you, Andre, for joining us. We also have Andre Ibawe, a technical officer for NCD management at WHO headquarters. Thank you, Andre. We have Tamar Khomasuridze, a sexual and reproductive health advisor for Eastern Europe and Central Asia with the United Nations Population Fund. We also have Alfredo Polo, a radiation oncologist in the Division of Human Health at the International Atomic Energy Agency. And Matthias Schuppe, team leader for the Cancer Task Force in the Director General for Health and Food Safety at the European Commission. Welcome, and thank you all for joining us today for this session. So, as you know, yesterday we released our new guide on cancer screening. And I want to start by talking about some terms that people might find confusing. And I'm going to start with a question for you, Andre Ibawe. We hear the terms in this screening guide. We hear early detection and early diagnosis and screening. And I was wondering if you could help by explaining the difference between early diagnosis and screening.
Thank you, Alison. And to begin, congratulations to our colleagues from the European Office and the broader European community for taking on such an important topic. This is an important and memorable day, and for us to spend it together, reflecting on how we can better serve the cancer community. The question you ask is very important. What, in fact, are those distinctions between early diagnosis and screening? Well, first, we have to recognize that there are two ways in which people present with cancer. First is that early diagnosis pathway. That is, they develop symptoms, and symptoms here is a key term. They ultimately receive care through a pathway and initiate treatment. Screening is a different process. Screening begins with people who do not have symptoms, people who are otherwise feeling healthy, and they thereby undergo a test to identify whether they may or may not have cancer or a condition that predisposes them to cancer. This should be done as a broader part of a screening program or activity. Fundamentally, the objectives are the same: detect cancer early, but the ultimate requirements for the health system are quite distinct. If we can summarize the differences in three ways. First, the volume of participants. For screening, the focus is on an entire population. This can be 50 or even 100 times greater in absolute number than the early diagnosis pathway. Second, health system requirements. Similarly, because of the larger population, screening programs require greater capacities to offer tests for that entire population, and by extension, can require a much greater budget. Third, and importantly, the potential for harm. Screening is a service to people who are otherwise feeling healthy, but a false positive or a false negative result can cause real harm. Accordingly, there's a greater threshold for benefit. Outlining these differences, it becomes clear that early diagnosis is the foundation for screening programs to be effective.
Thank you, Andre. And I am glad you touched on screening as a pathway and as part of a program as a complete cycle. And that's something that the screening guide also talks a lot about. And this importance of ensuring you have all the pieces in place and linked and accessible before starting a screening program. So following up on that issue of screening, there's a common phrase we often hear in awareness campaigns, and that is screening saves lives. And I'm curious if you agree with this, or if you find this statement misleading or even perhaps problematic.
This is a very important and complex question. There is no simple answer here. To begin, it is important to understand the value of screening, and that the value of screening depends on both the cancer type as well as the quality of the cancer screening program. Again, the overall objective is to reduce deaths from cancer, and that's a benefit to be offered to an entire target population, not this quote-unquote cure or saves lives. Not all programs do this equally. As a starting point, cervical cancer programs are a priority. It is because they reduce both the number of cancer cases and deaths from cancer. And this is why the Director General called on the community to eliminate cervical cancer as a public health priority. Meanwhile, when we look at other cancers, for example, thyroid cancer screening, in a general population, it can cause more harm than good if the cancer itself was not going to pose a risk to that individual in their lifetime. Second, screening can only save lives when it's done in a high quality and organized way. Ad hoc screening can also cause harm, more harm than good. But one other brief point to highlight. As a cancer community, we are focused on ensuring that cancer is prevented when possible, treated, and all people can have access to palliative care. The term saving lives can be challenging and problematic for the general population. Cancer screening programs, as mentioned earlier, are designed to reduce deaths. Using the term save lives suggests that people would immediately die without a screening test, and that is not the case. It is important as to why we encourage people to participate in screening programs. The objective of my comments is not to dissuade people, but to understand that screening programs should be designed through government agencies based on evidence and accordingly communicated to populations that it is important for those populations to receive a screening test. Now that is part of where that language comes from. Fundamentally, for screening programs to be effective, more than 70% of a target population should participate. This is why we see the language arise. Screening can absolutely benefit communities and populations. The term screening lives can often, as you raise, be a challenge with accurate communication, but fundamentally, the objectives of early detection are clear. early detection can benefit communities, can reduce deaths from cancer, and this is what we should remain focused on as a community.
Thank you, Andre. And there's several topics you raised in that we want to go into more detail a bit later. But I'm glad you raised the issue of screening for cervical cancer. And I see Tamar nodding her head. And I want to go to you, Tamar. I know UNFPA has introduced and supported cancer screening pilots in several countries across Eastern Europe and Central Asia. I was wondering if you could tell us about some of the challenges, but also some of the lessons learned from those projects.
Thank you very much, Alison. First of all, I'd like to express our gratitude for inviting me to this important discussion. Yes, UNFPA supports development of screening services in Eastern Europe and Central Asian countries over the last decade. During these years, we achieved a lot of progress, but there are challenges. As we are talking about cervical cancer, which is preventable, I'd like to prioritize the importance of continuity of the services after screening for those who need the follow-up, who need the treatment, as these services can reduce the number of new cervical cancer cases and also the deaths caused by cervical cancer. When we are talking about this challenge, there are root causes in health systems. And first of all, we see the capacity gaps among human resources engaged in screening services and in services for treatment of prior cancer and cervical cancer. Also, we see the gaps in financing, and we see the gaps in policies and national programs which should cover, in addition to screening, other services which can reduce the risks of cervical cancer, but also reduce the deaths caused by cervical cancer. Considering above, UNFPA supports countries in three interlinked directions. First of all, we advocate for evidence-based policies and programs which should cover comprehensive screening, diagnosis, and follow-up, including treatment. Second, we help countries to mobilize financial and technical resources to implement these policies. And third, and most important, we support countries to train national experts who are engaged in different components of cervical cancer prevention and treatment, including screening, including treatment, including palliative care. We believe that with our joint efforts, with our cooperation, we can eliminate cervical cancer as public health concern very soon in our region. Thank you.
Thank you, Tamar. And I think that message about continuity is so key. And thank you for raising that, because this is going to bring us back to the harms. You know, if screening programs are not linked to diagnosis and treatment that are accessible and effective, they can then do more harm than good. So let's talk a bit more than the harms and weighing the harms, the risks, and the benefits. There's a quote, and I'm going to read this for you. It says, all screening programs do harm. Some do good as well. And of these, some do more good than harm at a reasonable cost. And I'm going to go to Andre from IARC. So I want to know what makes screening programs effective for one cancer, but not for another. And let's take, for example, prostate cancer. Can you explain why the evidence does not support population-based screening for prostate cancer?
Hello, Alison. First of all, thank you so much for the invitation. Congratulations to WHO Regional Office for Europe for this initiative. It's so important to discuss, cancer screening and early diagnosis. So screening should be recommended when you have a good combination, that you have a disease that's suitable for early detection and screening, meaning that when you do detect that cancer, and you do detect that cancer in a pre-malignant status or in early stage, you can provide a treatment that either prevent the cancer to appear if you're treating a pre-cancer, or because you diagnose that in early stage, you prevent that person to die and decrease the mortality of the cancer. right? So this is one issue. The second one is that you need to have a test that have a good combination of sensitivity and specificity, meaning that when the test is positive, there is a great odds that the person has the disease, and when it's negative, that the person doesn't have a disease. And this is not the case for the prostate cancer, and I'm going to talk a little bit more about it, but it's the case for the cervical cancer with the HPV test. So you have to have those two combinations. And third, you need to have an infrastructure to do the screening test, the diagnosis test part, and to provide treatment, right? So you need to have those three parts combined in a good combination to promote one. For the prostate cancer, for instance, right, the screening program that some countries might be doing based on only the PSA levels is not cost effective and does more harm than good. Because if you use a high level to the cutoff of the PSA, you have a lot of false negatives because you have a high specificity and low sensitivity. And if you do a low cutoff for the PSA to call for a biopsy, you're going to have a lot of false positives that you're going to do more harm to biopsy a lot of men that don't have cancer. And then finally, right, what you have in the case of the prostate, even if you combine the PSA with other tests, you can increase sensitivity and specificity to detect cancer, but not to distinguish high-grade cancer from low-grade cancer from prostate. And low-grade cancer for prostate, it's overdiagnosed in most of the cases, meaning that the person has a cancer prostate that you diagnose, but the person was asymptomatic, and probably the person has more chance to die for other causes than from prostate cancer. So you're doing an overdiagnosis, treating cancers that would not harm the person in any level, and would do an over-treatment because you're going to treat that person because of the cancer diagnosis, providing sequela and side effects from the treatment. So with all this combination, prostate cancer based on PSA is of today, there is no indication for the populational based screening program.
Thank you so much. I think that's a great example of addressing, weighing the harms and the benefits of cancer, of screening. But that's an example of one cancer. But let's talk a little bit on the similar topic about within a cancer. I'm sure, we all know someone who's diagnosed with breast cancer in her 20s or 30s. So if we have the tools and we have the pathway in place, and this question's for Alfredo, why don't we start screening earlier? And how do we decide what ages are eligible for screening programs?
Yes, thank you, Alison. And let me thank you and all the organizing committee for inviting the IEA to this important meeting. We do appreciate very much. Going to your question, I think there are several angles to answer the question. First, even if you have the pathway and you have the tools, access remains a problem in many countries and in many regions within countries. So countries have to do a prioritization exercise and decide what type of screening programs are put in place. That means that there are other factors also affecting the implementation of services. And for mammography, for example, the quality assurance and the patient safety culture and the workforce and the work and the skilled workforce is also one of the limiting factors. If we go to the current recommendations, both the WHO, the best buys, and the position paper recommends screening in women every 2 years between 50 and 69. And there is a consideration for women between 40 and 49 if this is linked to the appropriate conditions and is linked to timely diagnosis and treatment. So this is certainly very important. But of course, there are groups of patients that may benefit from more focus and more screening started early, like BRCA mutations, for example. And there is another element that has to be taken into consideration is the balance between harm and benefit that has been mentioned before. We know there is overdiagnosis, there is overtreatment, and there is many times overexposure to ionized radiation to the patients. So in this sense, the principle of justification is very important, is one of the guiding principles in recommending and the use of a screening program based on ionizing radiation. In this sense, in terms of radiation protection, the IEA endorses the current approach to screening using mammography in this group of patients or in this group of population. And it's important as well to consider that there is some regulatory elements and that screening based on ionizing radiation has to be put in the context of the regulatory framework. So, in my opinion, it's a complex question, it's a complex answer, and there are many elements that play in giving the right answer to your question. Thank you.
Thank you for that. And following on that, this is a question for Andre with IARC. Can you explain why in countries we may see different target age groups? And can you talk about the role of epidemiology, demographics, and data in how those determinations are made and how the ages are set for different target populations?
Thank you again. So I would follow up, in Alfredo Polo comments, right? That we need to see very carefully this thing about the age when to start and when to end screening patients. WHO has some, overall guidelines on what is the best age together with IARC, what are the best ages or the average age that you should start and stop screening for each of the sites that screening is recommended. So when a country decides not to use that and try to tailor for this own population, first of all, we should call attention that cancers should improve their cancer register. The only way to see if you are outside the general target age that is recommended from WHO is if you have a good data to support it. And the second is that, usually people or countries would say that I have X number of cases in that age range, and that's the reason I want to do. But they don't look at their pyramid of the population that shows that indeed they have way more women on that age, and that the numbers, by only the numbers, will be higher. But we need to know about the rate or the proportion on how many women on that target age got the disease. And that's how you should interpret. So to implement the cancer screening, you should and change the target age, you should think about what is the cancer burden in your country. And you only know if you have a really good quality cancer register. And then if you want to change the target age, please look careful about what is the rate of that cancer site in your in that target age in your population.
Thank you for that helpful answer. And I think you're mentioning of the health information systems and the importance of registries and good data is so critical to an effective screening program. And that is going to link to my next question. We know that screening needs to be part of a pathway, but this also needs to be nested within a health system. And so this is a question for you, Matthias. Where do you see some of the gaps in health systems when it comes to cancer screening? And where should we be investing resources, human resources, financial resources, and attention to address those gaps in health systems?
Thank you. Indeed, screening is one of the key elements also of the Europe's Beating Cancer Plan that has been adopted by the Commission in February last year. And we are proposing to establish a new EU cancer screening scheme, which aims to provide screening coverage or reach 90% of the target population for breast, cervical, and colorectal cancer. The starting point and the key element in this screening scheme is the 2003 Council recommendation on cancer screening, which indeed recommends cancer screening for these three types of cancers, so breast, colorectal and cervical cancer. If you're now looking at the gaps, and 2003 is already some time ago, we have to say that still not all EU member states have organized screening programs for all these three types of cancer. Breast cancer is doing best, with almost all EU member states having screening programs established. Cervical cancer is the second one, and then comes colorectal cancer. We still have the majority of member states offering these screening programs, but unfortunately not all of them. And the second issue, of course, is if you have this population-based screening programs, how good is your coverage in the program? Again, we have a relatively large variation in the EU, with some member states indeed for breast cancer reaching already the 90%. For colorectal or cervical, we have 80%, but then there are other member states that are below 30 or 20%. And that's, of course, is an issue that needs to be addressed. We also need to look at low resource settings. So at some member states that have constrained resources, and there's perhaps also a balance that need to be struck. And of course, WHO is in the wider European region is facing a similar challenge, that we need to adapt the strategies also to the resources that are available in the member states. Data gaps have already been mentioned. So to assess the coverage, to assess the quality of screening programs is quite important. And of course, coming back to the screening recommendations, we need to update these and we need to provide guidelines. So one of the action in the Europe Beating Cancer Plan will be a Commission proposal to be published this year for an update of these 2003 Council screening recommendations, looking at what's the most recent evidence, what new technologies are available, but also consider whether other types of cancers, for instance, like lung or prostate cancer, could benefit from a population-based screening program. And for that, it's important that we also look at the evidence gaps that we have to address this issue. And last but not least, also to look at guidelines, for instance, for breast cancer screening and treatment, for which we have now already a European Commission initiative that has established both guidelines and a quality assurance program. And we are now working, for instance, on colorectal cancer, and will also address cervical cancer.
Thank you. And I'm going to take the privilege as a moderator to give a plug for also, I think, strengthening primary health care and universal health coverage to ensure access to services and to ensure that when someone shows up to their primary care provider, the primary care provider is aware and knows signs and symptoms, and also where in the health system the person should go next. But you also brought up the issue of disparities within the region. We have 53 countries in this region, and we know there are disparities across the region, both across countries and within countries. So this is a question for Andre and Alfredo. It's a two-part question. One is, what can countries do to balance both, limited resources and evidence? What do they do if they don't have all the resources available? We never have all the resources, right? The second piece of that question is there's also a tendency sometimes to jump for the technology. And what is the risk of this focus on the tool? And we talked a bit about this in yesterday's session, but what can you say about what are the risks of a focus on that tool or technology? Andre?
Thank you, Allison. And just to appreciate the important inputs from the co-panelists, what you're asking is very relevant for, as you said, countries at all income levels. From our perspective, there are three general steps in this decision-making process. First, to begin with what we heard from Matthias, is there sufficient evidence for the screening program? And are we confident that the evidence that exists justifies the benefits exceeding the harms in our context? Why start with this question? Well, as a point of reference, the reality is in many countries, screening programs do not follow the current best practices in a particular screening for cancer. As we know, in low and middle income countries, this is particularly challenging. A recent report from WHO showed that the majority of countries, in fact, are not following those evidence-based guidelines or are adapting them with insufficient local context. The second question then becomes, is this program going to offer us the greatest value for money? As you point out, we all have to make decisions and trade-offs given resources that are available. As part of the dialogue on universal health coverage, is this in fact part of the progressive realization concept? That is, before introducing new interventions, we should focus on those that are most cost-effective and ensuring that they are available to an entire population, with a focus on equity and solidarity. In many countries, again, screening is happening, but only for a small subsegment of the population. And in other countries, screening is being offered, but treatment services are not being financed. Third question, are we ready to implement it? Are the data systems in place, quality assurance processes, and how long will it take? Because in fact, screening is a marathon, it is not a sprint. It can take 10 years before a population sees benefit from a screening program. And this reflects on why it is such a major investment. Governments may want to consider whether there's adequate workforce, adequate infrastructure, and to be able to understand how to communicate with the broader public on the benefits of a screening program. The political context is real. Screening can offer a benefit to a population and be seen as in the broader political context. But we must communicate those time horizons and help populations understand why, when we have adequate evidence, when it does offer value for money, investment should be made. The question on technologies is very important. Perhaps Alfredo can comment on this as well.
Thank you.
Technologies do offer great potential, but should be seen in the broader context of, is there adequate evidence there? Please, Alfredo, over to you.
Thank you. Alfredo.
Thank you. Thank you, Alison, and thank you, Andre. I think you have covered many elements that are very important here. I think the countries have to concentrate on the ultimate goal, that is improving cancer outcomes. And this has to be through better policies that include screening and all the other elements in the cancer continuum, including diagnosis and including treatment. Implementing screening programs, implementing any type of technology-based health program is challenging many times. I think you mentioned, Andre, the opportunity cost is very important. What are the resources available and where the country want to put these resources? So analyzing the opportunity cost for these countries is very important. It's also important for those countries to understand and to define how to connect the screening program to diagnosis and treatment.
Can I stand
and
here?
how to connect
Okay.
also to primary care, as you said, Alison. Another two important elements that we stress all the time from the IAA is the culture of patient safety, the culture of quality assurance, and the problems that this may pose to implement quality screening programs, and also the need for a workforce, as I said before. Now, there are several perspectives to see the problem. One top-down perspective, where through policy making you try to implement the program. You may want to do a bottom-up approach, understanding the context. The context is everything for implementation. So by combining this top-down with the bottom-up approach is also critical for the successful implementation of these programs. Also, the financial commitment from the countries. A technical cooperation program is not enough. The countries have to put their financial resources and be able to sustain, to ensure the long-term sustainability of these programs. Regarding technology, again, implementing technology is challenging many times, but technology has to be based on evidence. The introduction of new technologies has to be based on clear scientific evidence. A phased approach is very important. What is the core, what is the expanded, and what is the desired set of interventions for the country. And based on this, do an adequate project management to implement every program. Technology has a value only if there is a workforce and only if there is a quality assurance system in place. Technology is a tool to achieve the goals, and the goals here is to improve cancer outcomes in the country, in the region.
Thank you.
Thank you.
Thank you so much. And this has been so informative. I thank you all for joining us. And I have one more question. And you mentioned workforce, and we have advocates. There's so many stakeholders involved in a cancer screening program. As we know, one of the key requirements for a screening program is high participation. You have to have high participation in a program for it to be effective. So I want to go to Tamar and Matthias, and I'm curious, what message do you have to partners, especially civil society, advocates, policymakers, on the topic of screening? And where do you see their strengths, and where do you see opportunities for further engagement? And the second part of that question is, what are your organizations doing to incorporate the patient voice? How are you understanding what patients are going through, and how can you use those voices to help understand how to reduce barriers to participation in these programs? Tamar?
Thank you, Alison. I think this is a very important question. I'd like to start my key messages with first and most important. Civil society and women's groups are our major advocates, our major supporters, but also our major advisors, how to organize client-organized, client-centered, client-oriented services for cervical cancer prevention and its elimination. In several countries, we have good examples when UNFPA supported creation of supporters groups consisting of people and women affected by cancer. Also women volunteers who are working with service providers, with policy directors, policy makers. And we found that the policies which are developed with participation of civil society groups, and especially the people affected by cancer, they are efficient, they are more acceptable and better accessible by all people who are in the target groups. These experiences now should be shared at the regional level and global level. What UNFPA is doing in this regard, we support civil society participation and engagement of partners from different sectors at the national, regional, and global level. Last year, through our initiative, the Regional Alliance for Cervical Cancer Prevention became operational. This is the regional body where the decision makers, academia, private sector, and civil society groups are represented. And we see this framework as main vehicle to bring the experiences of developed countries to the countries where such movement, such activism of civil society is not strong enough. We also see the opportunities of cooperation with some global networks, and we see the opportunities of strengthening the international networking of women's groups and civil society organizations, which are active in the countries of Eastern Europe and Central Asia. Such groups need more international exposure, networking with European Union countries and international global organizations. Thank you.
Thank you. Before I go to Matthias, I just want to say, especially I think giving opportunities to these organizations to learn from one another by linking them across the region is really important, so they can share lessons learned, and providing them. I think the information that you have all provided today is critical also to those organizations, so they understand the evidence and know what and what to advocate for when they're meeting, when talking with policymakers. But Matthias, I want to go to you.
Yes, thank you. I think Tamara has already highlighted most of the key features here in terms of civil society and advocacy groups and their role. I would see it on one side in dissemination and advocacy, in the expertise that they have, and of course also in the implementation of the relevant measures. So for instance, when we talk about dissemination and advocacy, one instrument that we have at EU level is the European Code Against Cancer, which was developed by IARC and which we will update jointly with IARC in the coming years. And civil society is playing an important role, not only to ensure that these messages and recommendations in the code are understandable for the lay person, but also to disseminate these messages. And one of these messages is indeed to participate in cancer screening programs. Then another element, as I mentioned, is the expertise. And here we have several mechanisms at the EU level. We have, for instance, with the adoption of the cancer plan, of the Europe-Speaking Cancer Plan, established a stakeholder contact group under the Commission's health policy platform. So here we have a mechanism to engage with civil society, and we also have then thematic networks, for instance, one focusing on cancer screening and early diagnosis, in which we regularly exchange with relevant NGOs and advocacy groups, including patient groups. Another element is more specific and focusing on individual actions. For instance, for the update of the Council recommendation on cancer screening, which we are preparing now, we have actually launched last week a so-called call for evidence. That's basically a document that outlines what the Commission is planning and invites all stakeholders to provide feedback on that. And stakeholder groups have now 4 weeks time until the end of February to provide feedback to the Commission to influence basically our course of action and the development of policy in this area. And last but not least, of course, the implementation, where we regularly have relevant calls under the EU for Health program, offering support and making calls for proposals to civil society stakeholders to implement actions under the cancer plan, including on cancer screening. So we have currently still a call open for the implementation of breast cancer screening and piloting of quality assurance schemes. That one will close on the 17th of February. And we have announced also in the work program 2022 additional actions focusing on cancer screening and early diagnosis in the area, for instance, of breast and lung cancer. So these are the 3 areas that we're trying to use and engage with civil society in the Europe-Speaking Cancer Plan.
Wow, thank you. That's a lot of information. And I think something you highlighted in there also was communication, dissemination. And I think we cannot underestimate the role and the importance of communication in helping people understand the evidence and why to participate in screening. So I think this is a perfect place to end and conclude our session today. I want to thank all of our panelists, and I want to thank everyone who's joined us. I think this was an extremely informative session today, and I hope you also found it useful. And I think, I want that to recognize the partnerships here and thank all of our partners who have joined us. And we look forward to continuing to work with you in the year ahead in the United Action Against Cancer. Thank you and good night.